It all depends on our willingness to share as one nation.
A transformed health system that will not just have better health outcomes.
Our issue is about saving lives.
Save money for individuals, households, and the country as a whole.
The NHI should cover all South Africans and offer all the services to South Africans.
This week on NHI Now, we talk to Dr. Nicolas Crisp, a consultant for the Department of Health in charge of establishing the administrative and operational infrastructure for implementing NHI. He will be answering questions on why South Africa needs NHI and what are some of the benefits of NHI. He will also explain how citizens will access medical services under NHI and what will happen to medical aid schemes once NHI is implemented.
The starting point is that NHI, National Health Insurance, is a financing system that by the structure of that financing system will steer reforms in the way that services are delivered. So why we need it is because our current health system is extremely disjointed, many role players, two completely different parallel systems, neither of which is very efficient, and both of which are quite wasteful. We hear the statistics regularly in the media, so just to summarize them, about 86% of the population is primarily dependent on the public sector, which has about half of the resources, and the remaining 16% of the population has access to the other half of the resources. There's obviously quite a lot of mix across the two sets of user groups and even across some of the provider groups. But that's broadly speaking what we are dealing with. And currently as a country, we spend over 8.5% of our gross domestic product. So of everything that we as a country earn, the 8.5%, almost 1/10 of everything we earn in this country collectively, we spend on healthcare. So that should be enough for us to look after everybody. However, we have very poor outcomes, even compared with countries who spend way less money than we spend, and it means that we are doing something drastically wrong. So why we need national health insurance is to completely redesign the way in which we pay for and deliver the health services in this country. No, so that's public and private and whether we spend it out of pocket, whether we spend it in taxes, or whether we spend it by buying health insurance through medical schemes. That's the 8.5%. So more or less half of that is paid in taxes, and we get it through the services of a public sector provider. The other half is, the bulk of it is prepaid medical health insurance, which we buy in South Africa through two means. The one is medical aids and the other one is medical insurance, like top-ups and things. And then there's a significant portion which we as South Africans spend on out-of-pocket spending, where we go to a pharmacy or we go to a doctor or a dentist or somewhere else in the health system, and we pay directly for that care because it's not covered by our insurance, and we don't want to use the public sector. That collectively is about 8.5%. So what NHI, the objective of NHI is to try and pool all of our resources. So instead of us ensuring small groups of people with similar interests, where healthy people insure themselves, and it becomes more and more difficult to insure the elderly or the people who have chronic illnesses as a group. So the amount of money they're about to put together. For lay people to try and understand, maybe the concept of a stokvel is something for people to think about. You pool your money, and the more of you who are contributing to the pool, the greater the amount of money that's available for us all as members of that stokvel to benefit. It's not dissimilar in the insurance world. So in NHI, what we're saying is that we need to pool this not as an insurance company, but as the nation. So one way to do it is to pay it in taxes to the government, and the government then puts that money into a big fund, and we spend that money out of the fund, where if I'm sick today, I know that there's enough money in the fund to care for me, because I might be well for the next 3 years, but somebody else might be sick, devastatingly ill with huge costs. So what NHI is trying to do is to pool enough money to provide what we call universal health coverage. So the three facets of the pooling of universal health coverage that we're trying to achieve with this, and these are big terms and people don't necessarily understand the terms. We're trying to increase the number of people who have access to healthcare. So that's a pure numbers game. You might say everyone has access to healthcare in South Africa, and in theory everybody does, but the poor do not have the access that the rich have. It's as simple as that. So we want to increase access. We want to increase the second dimension in universal health coverage is to give greater coverage, more services, a broader band of services. So if I live in rural Vembe or in rural Eastern Cape somewhere, my access to health services for cancer treatment, to get diagnosed, treated and supported, is significantly poorer than someone in an urban area, especially someone who has money. So the second dimension is to make those services accessible to a larger number of people. The third dimension is taking out my personal risk and your personal risk as users of the system, that I don't have to pay in money, as much money as I pay now when I get sick. So right now, if I'm a very poor person, I go to a government hospital and I pay almost nothing for my health care. If I have access, if I can get there, if I can sustain the transport and the whatever else. So there are other dimensions to access. If I'm a wealthy person, or I have means and I'm employed, I might have a medical aid, but I might have to pay in because what I've insured myself for did not cover the condition I now have for which I need care. So I have to pay in anyway. So what the National Health Insurance does is it removes that risk to me as an individual, and to whether I'm poor or whether I'm rich, I will not have to pay at point of care when I'm sick. The whole point of it is that the reason you get treatment and the treatment you get is related to your condition at that time. It's not related to whether you are wealthy or whether you're rural or urban or whether you are able to pay or unable to pay. That's what the National Health Insurance is trying to achieve. Okay, so we're a long way away from the full implementation of an NHI, because what has to happen is that you need the government, the agency that is being created called National Health Insurance Fund, which is going to be a public entity, still needs to be set up officially, get its operating procedures and administration in place and so on. So although the government has been putting a lot of those mechanisms in place for some time now, it still has to be operationalized. And the content, the goods that you and I will want to know about, what are the benefits, where do I get my benefits, what are the rules of my engaging with the system, will still need to be put into the public space in detail so that every one of us understands where to go, how to go, what I'm covered for in a particular facility, how I will be referred, etc. The details of that are going to take time to evolve. I don't want to get into the complex administrative arrangements around that, but it does take time. So for the foreseeable future, medical aids will remain in place. That they may change, and these things are adaptable and they do change over time. But for the foreseeable future. But by the time the NHI is implemented, what the bill says and where we are headed is that whatever is covered in the package of benefits, the services that are going to be paid for through the fund from the tax fund money that is put into the fund, anything that is covered in the fund may not be covered by a medical aid. But anything that is not paid for in the fund may be paid for by a medical aid, and those who have additional resources may insure themselves through that, whatever the medical aid structure is at that time, to be able to do that. So the bill does not say that medical aids are banned or going to be banned. But what it does is it restricts what they are going to do and how they're going to cover. Exactly what is going to be included in the benefits package and what is not going to be included in the benefits package will evolve over the next years. And the bill refers to a period or a phase that will end in 2026. So between now and then, it will become very, very clear what is included and what is not included. The bill says that the fund will purchase, not may or will purchase, from both public and private providers. But any provider must comply with a certain standard, and that standard is regulated through standards by the Office of Health Standards Compliance. And once they comply with those standards, they can then be accredited to provide a certain package of services, and the bill lists some of the conditions in which any facility will be accredited, and obviously the nuts and bolts of that will come out in regulations and operational procedures, as I've alluded to. There are very good public health facilities in South Africa right now, and there are very poor public health facilities. And it is unfair on those people who work really hard and who strive every day under very difficult circumstances to maintain and look after their facilities, equipment and services, to refer to them in one bundle with those who really are bad. So I think we need to acknowledge the people who really work hard to keep their facilities looking good. Government is a big animal that includes the National and Provincial Department of Health and a whole lot of municipal structures. Collectively, those administrations, with the budgets available to them, have been busy for some time now and now have accelerated their efforts to improve the facilities in the public sector. And that has many dimensions. One of those dimensions is the capital infrastructure, refurbishment of things that really are bad, replacement of facilities that are very old and defunct or not purpose designed that are currently being used, and in some instances creation of new capacity either within existing facilities or completely new facilities. And there's a lot of work that is going on around the country in all 9 provinces to improve the physical infrastructure. You don't see it because it's dispersed, but it's enormous what's going on. And there's a process that is underway with Treasury and other players to see if we can accelerate and do more of that capital refurbishment. The second part and associated with that is a move to improving the maintenance of technology, specifically bigger stuff like X-ray machines, the anesthetic equipment and so on. So they don't go down, because if they're down and they're not working, it means you can't deliver that service and the patient backlog becomes more of a problem. So that's the second major effort that is going on in all the administrations. The third one is a very specific program to try and improve human resources in the public sector. So you can have all the equipment and the buildings, but if you don't have the people to do the work, and if you don't improve morale and the way in which the staff interact with the public, you don't have a service. That, of course, is complicated, and there are many role players involved, and some facilities are doing very well with their program and others are doing less well. But all in all this adds up to quality improvement. Facilities in the public sector will not get full accreditation if they haven't got compliance with the basic standards and if they are unable to deliver the services. So they have pretty much 5 years by the time the NHI comes online to comply. And all these aspects are being steered through a process of a total quality management, total quality improvement program with learning centers, which we'll be speaking more about in the future, where we'll start with a few facilities and then others will learn the process from those facilities. But it extends into clinical governance, which for us, we talk about it as health practitioners of clinical governance, but basically the care that you get, not the environment within which you get it that I've been describing, but more the care, the actual clinical decision-making process, and the medicines you get and the devices and so forth. So these things are all happening in parallel as part of this total quality management program.